are presently caught up in the city of Wuhan.
Indian nationals are about to board very shortly an Air India special flight from Wuhan.
पूरे देश में आज रात 12 बजे से संपूर्ण देश में संपूर्ण लॉकडाउन होने जा रहा है। हिंदुस्तान को बचाने के लिए, हिंदुस्तान के हर नागरिक को बचाने के लिए, आपको बचाने के लिए, आपके परिवार को बचाने के लिए आज रात 12 बजे से घरों से बाहर निकलने पर पूरी तरह पाबंदी लगाई जा रही है।
In January 2020, as winter tightened its grip on Wuhan, a 20-year-old medical student from Kerala packed her bags to come home. She had been studying at Wuhan University, where whispers of a mysterious pneumonia had already begun echoing through the city. Markets were shutting down, streets were empty, and yet no one truly knew what was coming. She boarded her flight from Wuhan to Cochin to reunite with her family. At that time, India had no confirmed cases of the new coronavirus. She went home unaware that she carried something invisible. Within days, she developed a dry cough and mild fever. Her parents took her to the local hospital, where the doctors collected a throat swab and sent it to the National Institute of Virology. On 30th January, the result came back, positive for novel coronavirus. India had just reported its first COVID-19 case. She recovered, but the story didn't end there, because from that single case, questions began to rise. How did that virus cross borders so swiftly? And what made this infection spread so efficiently, defying all containment? To understand that, we must look deeper into the agent, the host, and the environment, the triad that shapes every epidemic in human history. At the center lies the agent, SARS-CoV-2, a positive sense single-stranded RNA virus belonging to the beta coronavirus genus. Its defining weapon is the spike glycoprotein, a trimeric structure that binds with high affinity to the ACE2 receptors expressed on human respiratory and gastrointestinal epithelium. Following receptor engagement, facilitating membrane fusion and viral entry, a process that gives this pathogen extraordinary efficiency in colonizing human airways. The primary reservoir is now human, with sustained person-to-person transmission, zoonotic origins likely from bats, possibly via an intermediate host. But human amplification is now the dominant cycle. Viral particles are shed abundantly in respiratory secretions, and under conducive conditions can remain viable on surface for several hours or days, expanding transmission potential beyond immediate contact. Next, the host, the human being. Host susceptibility is shaped by age, immune competence, and metabolic health. Elderly individuals and those with comorbidities like diabetes mellitus, cardiovascular disease, chronic lung disease, or obesity exhibit a dysregulated immune response, often progressing to respiratory failure. Conversely, young and immunocompetent hosts may remain asymptomatic, yet contribute significantly to silent transmission chains. And then the environment, the stage upon which the virus and host interact. Environmental parameters like poor ventilation, humidity, temperature, and above all, population density govern the effective reproductive number. When these three forces align unfavorably, an epidemic becomes inevitable. But what happens next inside the human body is where theory meets reality. SARS-CoV-2 infection exhibits a broad clinical spectrum from asymptomatic carriage to critical illness with multi-organ failure. Most common symptoms as per WHO are fever, dry cough, tiredness, and loss of taste or smell. Less frequent symptoms include sore throat, headache, myalgia, diarrhea, skin rashes, conjunctivitis, nasal congestion. In some cases, infection progressed to serious disease like dyspnea, chest pain, hypoxia, ARDS, multi-organ dysfunction. According to Ministry of Health and Family Welfare Clinical Guidelines 2023, they classify cases into mild, moderate, and severe categories. For mild disease, the patient may have upper respiratory symptoms and or fever without shortness of breath. For moderate disease, respiratory involvement is present with signs of pneumonia but no hypoxia. Severe disease show respiratory distress and respiratory higher than 30 per minute or SpO2 less than 90%. Many patients who appear mild may worsen over days, so close monitoring is critical. Coming to the diagnostic approach, clinical suspicion alone cannot reliably distinguish COVID-19 from other respiratory infections. Confirmatory testing is essential. The gold standard is molecular testing, typically RT-PCR, which detects viral RNA in respiratory specimens. Antigen or rapid test provide faster results by detecting viral proteins, with lower sensitivity, especially in asymptomatic or low viral load cases. For a valid molecular test, proper sampling technique and specimen type matter. Common sample includes nasopharyngeal or oropharyngeal swabs. Sometimes sputum, bronchoalveolar lavage in severe cases, or saliva can be taken. Specimen handling, cold chain, and laboratory quality control are critical for accuracy. Clinicians also use ancillary diagnostics like chest imaging and laboratory markers, which includes X-ray and CT thorax, showing ground glass opacities, bilateral infiltrates, patterns seen in COVID pneumonia. Laboratory markers may include lymphopenia, elevated C-reactive protein, D-dimer, ferritin, LDH, interleukin 6, and derangements in liver and kidney function as severity markers. From here, we will explore global burden of disease and how India and specifically Punjab bore the weight of this pandemic. Every pandemic leaves behind more than numbers. It leaves behind a weight of loss, of recovery, of what's never the same again. COVID-19 wasn't just a virus. It was a test of how much our system and our people could carry. Globally, over 760 million infections were recorded. In India, over 44 million. But the real burden, the strain on hospitals, doctors, and family can't be seen on these curves. World Health Organization calls it the burden of disease. Not just death, but years of healthy life lost. India lost millions of those years to hospitalization, to delayed care, for other illness, and to something we are only beginning to understand: long COVID. Studies across India showed that even months after recovery, patients struggle with fatigue, breathlessness, and cardiac issues. Ministry of Health and Family Welfare's post-COVID guidelines calls it the next wave, a silent one. And then there's Punjab, a state with older population, high rates of diabetes and hypertension, the perfect storm for severe COVID outcomes. In 2021, Punjab registered over 2.68 lakh deaths, but only around 11,000 of them were officially recorded as COVID deaths. That's the hidden burden. Deaths outside hospitals, deaths uncounted, families without closure. Hospitals in Ludhiana and Amritsar overflowed, oxygen supplies ran out, and people behind every number there was a doctor, a nurse, a family fighting to keep someone alive. By early 2023, WHO showed India's hospitalization curve finally flattening. Long COVID clinics now report chronic fatigue, lung fibrosis, depression. The pandemic didn't just end, it settled in. Punjab still carries that burden in its hospital, in the households, in its silence. The Ministry of Health and Family Welfare, guided by WHO, issued its first national advisory in early 2020. Simple rules: distance, hygiene, and mask became the world's new armor. It wasn't just about personal behavior, it was about systems. Infection controls in hospitals. Every hospital became a fortress. Then came science's greatest comeback: vaccines. India launched the world's largest immunization drive in January 2021, deploying Covishield and Covaxin under a nationwide cold chain network. For a country of 1.4 billion, this wasn't just a medical operation, it was a logistical miracle. But not everyone could be protected in time. For those who fell sick, India's clinical response evolved rapidly, from system based care to a tiered management system built on science. Mild cases were managed at home with monitoring and hydration. Moderate cases needed oxygen therapy, sometimes steroids like dexamethasone. Severe cases required ventilation, intensive care, and sometimes experimental antivirals. It's 2025, 5 years since a microscopic virus reshaped human history. Today, India stands in a new phase, not crisis but caution. The WHO reports a slow global resurgence with test positivity again touching 11%, reminding us the virus never truly vanished. Here at home, the Ministry of Health and Family Welfare dashboard shows barely a few active cases, yet new variants quietly circulate across states like Kerala, Maharashtra, and Punjab. Most infections are mild, but they raise familiar questions. Have our defenses evolved as fast as the virus has? For a nation that once fought on the edge of collapse, 2025 is a story of resilience and vigilance. Learning to live with the virus that still learns how to survive.